It's again up to me to present the next speaker, who is Claus Vogelmeier from Marburg, who will talk about similarities and differences between COPD without obstruction and heart failure without, I guess, reduced ejection fraction.
Don't touch.
I don't touch it.
Ah, okay, sorry. Yeah.
No, up here.
Okay.
No, wrong.
No.
Sorry.
This one.
Please.
Mr. Chairman, ladies and gentlemen, typically 1 or 2 weeks before I give a talk, I look at the program. This time I thought, oh my God. What is this all about? And for those of you who have the typical post-lunch tiredness, don't worry, just take a quick nap. Now, this is really a very difficult topic that I'm supposed to talk about. And this will be a talk for non-cardiologists. So the cardiologists in the room, they may leave right away. The point with heart failure in patients that have preserved ejection fraction is that clinically and pathophysiologically, the situation is different from systolic heart failure. To make the story very simple, while in this situation that you see on the left, the hearts get big and the systolic function is deteriorated or is less than normal, whereas in diastolic heart failure, what you see on the right-hand side, what you typically find are normal size left ventricles with thick walls, and the problem is that they cannot fill adequately during the diastole. So that's the major difference between the 2 points. And I would like to cover now several aspects where I will compare data for this, what I called it, to simplify the story, goal 0 COPD, the one that Jerry just presented to you, and heart failure with preserved ejection fraction. That's the abbreviation that you see on the right. So when it comes to diagnosis, how do we diagnose this goal 0 COPD? This is the outline of the study that Jerry just showed you with these more than 4,000 individuals that had this preserved lung function. And they did it by several ways, and one of the ways they did it was by doing CT scans. And here you see what they saw, that over time there was an increase in current smokers and in former smokers. The light gray bars represent former smokers, the dark gray bars current smokers, regarding patients that had signs of emphysema or gas trapping in the CT scan. So this seems to be very much age dependent. Now, when we look at the comparison between systolic and diastolic heart failure, what are the similarities and differences? So by definition, there is a difference in ejection fraction. Signs and symptoms are extremely similar. I mean, we have on our intensive care unit, we see a lot of patients with COPD that are admitted to the intensive care unit with severe respiratory failure. And then always the discussion comes up, is this COPD exacerbation or something else? And one of the differential diagnoses that we have to deal with nearly every day is congestive heart failure in patients that very often have preserved ejection fraction, that have diastolic heart failure. Now, the signs and symptoms of the two are very similar. There is no significant difference in mortality and morbidity. I will show you that in a minute. Then BNP and anti-pro-BNP levels may be elevated, or they are typically elevated. And when they say here more or less elevated, that's stupid nonsense because you cannot use it on your daily clinical practice. Sometimes you see patients with pure diastolic heart failure that have very, very high values of BNP and anti-pro-BNP. And regarding treatment, there is a major difference that I will show you in a minute. Now, what are the patients that develop this kind of heart failure? Again, as you have seen in the goal 0 patients or the individuals, this is a very age-dependent situation. When you look at the prevalence, the mortality and morbidity, you barely find it only in a limited number of patients that are less than 50, whereas the older the patients get, the higher the prevalence is, and the higher the morbidity and the mortality. Now, how do we diagnose this kind of scenario? This is a slide from the guidelines of the European Society of Cardiology on heart failure. By the way, this is a fantastic guideline that's very well written. And here you see the comparison between patients with reduced heart failure or reduced ejection fraction and preserved ejection fraction. And not surprisingly, here you find a reduced ejection fraction. Down here you should not find that. And in addition to that, the left ventricle is not dilated. But you may see other things. In particular, you may find, or you must find, signs of diastolic dysfunction. So when this whole discussion started about these patients, in the beginning, it was clear that you cannot make the diagnosis without echocardiography. And initially, this was only based on the analysis of the mitral inflow pattern. But now we have much more sophisticated ways of looking at that. So you see up here, normal diastolic function, mild diastolic dysfunction, moderate, and then you see different forms of severe diastolic dysfunction, and you see the different mitral inflow patterns. So this is sort of the easiest way or the most simplest approach to this problem, but you see there are many other parameters now that you can look at. A major progress was made by doing tissue Doppler imaging. The problem is that most cardiologists do not really care about that, at least in my country. They do not really care about diastolic function, and so you very often, when you ask a cardiologist to do an echo on a patient on the intensive care unit, the only message that you get, systolic function preserved. And this is not very helpful when you think about this kind of scenario. What's about prognosis? We already discussed the problem that we do not really know what the prognosis, Manuel mentioned that we do not really know what the prognosis of these gold zero patients is. When you look at the lung function parameters that we have so far up here from the never smokers in the group, the gold 1 smokers in the group, and the gold zeros, this sort of would suggest that sort of more or less this is a movement from there to there, and therefore you would imagine that these guys someday will develop overt COPD. But as Manuel mentioned, this is not clear, and maybe COPD gene will give us the answer what the prognosis of these gold zero patients is. How does it look with diastolic heart failure? This is a totally different story. These guys are typically in bad shape. Here you see a paper from the New England Journal where you see on the left-hand side patients that are admitted with inhaled, with a preserved ejection fraction, the percentage of patients with heart failure. And you see the percentage is going up dramatically over time, and in 2002, more than 50% of the patients with overt heart failure admitted to hospitals had diastolic heart failure with preserved ejection fraction. And on the right-hand side, you see the comparison between patients with preserved ejection fraction in red and reduced ejection fraction in white. And you see this is like an X, so the patients with reduced ejection fraction go down, whereas the other ones increase. When we look at prognosis, it does not make a difference if the ejection fraction is reduced or preserved. The prognosis in these patients, when they have heart failure, is bad. You see here, 5-year follow-up period in black, reduced ejection fraction, and in red, preserved ejection fraction, and the curves are nearly identical, suggesting that it makes no difference regarding prognosis what the problem of the heart is. Now, this is a very nice analysis where patients, only studies were included, where patients at the beginning of the study had, by echo, left ventricular dysfunction and no overt heart failure, and then they followed up these patients and looked how big the risk was that over time they developed overt heart failure. And on top, you see the patient with diastolic dysfunction, at the bottom with systolic dysfunction, and when you look here at the summary graphs, although the risk is not as high for patients with diastolic dysfunction compared with systolic dysfunction that they may develop overt heart failure over time, there is a risk of about 4 compared to patients that do not have that they will develop overt heart failure over time. So there seems to be a continuum from the echo finding to the clinical scenario later on. Now, there is a lot of discussion in the cardiology world, what is the difference between diastolic heart failure and systolic heart failure? And this is a very nice analysis that uses a totally different approach. They do not care about diastole or systole. They use something what's called mean regional myocardial sustained velocity. It doesn't matter what it is because there are other studies that with different approaches looked into that. And what they find here is if you look at patients with systolic heart failure and patients with diastolic heart failure compared to normals, when you analyze this parameter, there is no major difference between the two groups, suggesting that these are just two extremes of the continuum of heart failure. So at one end of the spectrum, you have the patients with pure diastolic heart failure. At the other end of the spectrum, you have the patients with pure systolic heart failure. But it doesn't matter. The function of the heart is very bad anyway. Now, role of comorbidities. There is a nice study in the Blue Journal that analyzed patients with very early COPD regarding the role of comorbidities. It was published in 2014, and they had smoking controls, never smoking controls, and what they call preclinical COPD. These were individuals where the diagnosis was made by spirometry screening. They did not have symptoms while they sort of why they visited their doctor. And then they did objective evaluation for all kinds of comorbidities. And this is what they found. On the left-hand side, you see cardiovascular disease. In the middle, metabolic disease. On the right-hand side, musculoskeletal disease. In white, you see never smoking controls. In gray, smoking controls. And in black, this is what they call preclinical COPD. And as you can nicely see with regards to cardiac dysfunction, there is a major difference between the three groups, suggesting that there is a major sort of relation between patients with an early COPD form and a cardiac dysfunction. Similar data have been obtained for patients with diastolic dysfunction. So all kinds of comorbidities have been looked at, and some strange findings came out of that. This is a paper where this was analyzed, and here you see obesity on the left-hand side, in red patients that are obese, on black patients that are not obese, and obviously obesity protects you when you have diastolic heart failure. With anemia, it's the other way around. In red, you see the anemic patients. In black, you see patients without anemia, and there is a survival benefit for those without anemia. What is counterintuitive is that diabetes doesn't play a role here regarding prognosis, and the same is true for renal dysfunction. Patients with renal dysfunction, here, the survival was worse than for patients that had preserved, that has a preserved glomerular filtration rate. What about exacerbations? We don't know anything about exacerbations in the group that Jerry presented to you. At least I'm not aware of any data. Whereas we know quite a lot about exacerbations in patients with diastolic heart failure. That's I would say, a landmark study published in New England around 15 years ago. And here they evaluated the left ventricular ejection fraction during acute pulmonary edema and 1 to 3 days after that. And what you nicely see up here, when you look at these patients, left ventricular ejection fraction after treatment, you see many of these patients with pulmonary edema had normal ejection fractions. Coming back to what I said in the beginning, that nowadays we see many patients with pulmonary edema where the left ventricular ejection fraction is preserved and not reduced. What about treatment? As Jerry told you, although these patients that he showed you would not qualify for therapy, a lot of them are treated for obvious reasons because they have symptoms, and doctors feel that they need to do something about it. What about the treatment of diastolic heart failure? First of all, whatever the treatment is, it obviously doesn't work. Here you see statistics from patients with reduced ejection fraction on the left and with preserved ejection fraction on the right, and you see then the time. Here in black, the end of the 80s, in red, 90s, and in blue, 97 to 2001, and you see that the prognosis gets better with regard to reduced ejection fraction. But this is not true for patients with preserved ejection fraction at the same times, but the curves are practically identical. Dr. Ciccioni has already shown you the guideline for the treatment of heart failure with reduced ejection fraction. This is the graph on the right-hand side. It doesn't matter that you cannot see the details. This is a great success story. When I was a young fellow, I come from Munich, and I'm not only a pulmonologist but also a cardiologist, so I saw all these patients that were sort of that were ready for heart transplant at that time. And then these guidelines of that kind came up, in particular these first beta blocker studies, and all of a sudden, many of these patients didn't need transplants anymore. So this is a real great success story. Whereas this is very different for diastolic heart failure. So here you see from the same guideline from the European Society of Cardiology, the most important sentence or the bullet point is this one. All the other wording is just a typical English way of hiding the fact that there are no data. Whenever it says may, you may or may not, it tells you that it doesn't work. So there is a lot of wording that you can do something about diuretics, then you can treat hypotension, that you can do something with atrial fibrillation, that you may try a calcium antagonist, and also a beta blocker. But the fact is that all the trials that have been performed to find out if this makes any difference failed. And a typical example is this one. This was one of the most prestigious studies published in the New England Journal with irbesartan in a huge number of patients, more than 4,000 patients that had New York Heart Association 2, 3, or 4 heart failure with a preserved ejection fraction. They got the typical dose, were followed for a long time, and there was a primary composite outcome of death from any cause or hospitalization for a cardiovascular cause. And this is the curve or the graph for the primary endpoint. It doesn't matter what the lines represent, there's no difference. So it doesn't make any difference what you do. These treatments all don't work. So to summarize what I've shown to you, when we compare COPD goal 0 with heart failure with preserved ejection fraction, the diagnosis from the COPD is based on symptoms and spirometry and risk factors and CT scans, whereas the diagnosis of HFpEF cannot be made without a good echocardiography. So without echocardiography, there's no chance that you will be able to make the diagnosis. The prognosis here is unknown. Here it's undoubtedly bad. The role of comorbidities, for both diseases, comorbidities seem to be relevant. Exacerbations, we don't know that much about goal 0 patients. There is no doubt that the classical exacerbation of patients with preserved ejection fraction is pulmonary edema, and as we know, this is a very critical situation. Regarding treatment, there are 2 question marks. We have no idea what to do about that. Now, the most interesting question from my perspective is there any relationship between the 2 diseases? Is it possible that sort of this early COPD has an effect on the heart and the other way around? The answer is we don't know, of course, but I think this should be looked at, because I think that the interactions between the heart and the lung are extremely complicated and extremely interesting. And to give you one example, this comes from Helgo Magnussen's group. In Hamburg, they evaluated the correlation or the relationship between the left ventricle end-diastolic diameter and the hyperinflation of the patients. And as you can nicely see, the more hyperinflated the patients are, the smaller the ventricles get. And first of all, you would think, what is this supposed to mean? I mean, the left ventricle this is a very strong muscle. Can you compress this by increasing pressure in the thorax? That's probably not possible. But what probably is happening is that the big veins are compressed by the changes in the thorax, and thereby the backflow, so the preload of the heart changes, and thereby the ventricle gets smaller. And these may have major consequences regarding the circulation, regarding, for example, how much blood gets into the coronary arteries and so on. So this is, from my perspective, an extremely important topic that needs to be clearly looked at. Now, to finish, I think the basic message that I wanted to give you is that COPD is not COPD. This you have known all along. But now you have in addition learned that heart failure is not heart failure. So with this I'd like to end, and if you didn't like it, blame it all on Leo. It was not my fault. Thank you very much.
Thank you very much. Open for discussion, please.
Thank you very much for mentioning our study. But what is important in relationship to COPD Goal 0 is a bar study, which has been published more or less at the same time as our study. And these people which performed the CT, they have very, very good FEV1 data. FEV1 data were more or less normal, but they have changes in the CT. And they speculated that all the lung-heart interaction was based to hyperinflation due to the very low decreased FEV1. This may also be an explanation for the findings you mentioned.
Yeah, but there was a lot of discussion about the bar data because, as you said, nearly all these patients were not sick. And therefore the question comes up, what does this really mean when you have 95% of all the data points in the normal range and only a few of them are sort of pathologic, then what does this really mean? So I think this discussion is still not ended.
Next.
Leo.
Yeah, I suspect there are no data, and I thank you for addressing a very difficult issue, but I wonder whether the cardiologists look at the lung, and if Jerry is still here, whether anything was looked upon in the CT scanning for the heart in people with symptom and normal lung function.
Jerry, can you comment on that? Did you look at the CT scans regarding how the heart looks like?
Yeah, there's no data on that yet, but George Wasco and his group are trying to. We don't have data.
Okay, another question, please, Manuel?
One other possibility for the, that might link together these early diseases in these people that we learned that the residual volume is increased, so they are breathing at higher lung volumes, and that will increase the afterload. And that is, consistent. The other thing that's interesting is, especially in the bad group of the gold zero, the ones who were obese and had more chronic bronchitis, they might have a degree of sleep apnea that would certainly, that would be a bad thing for the heart also, and that there would be something to consider. But just the increase in the residual volume may be an important one to.
Yeah, this would go in the direction that you have more sort of afterload regarding the right ventricle. But now there are also data that show that also the right ventricle gets smaller in COPD. They call it corpulmonale parvus. So that's a new kind of term that's been introduced last year. And that's also an interesting story. Why don't we see these patients with these huge right ventricles anymore? When I was a young fellow, we had tons of these guys. And now they are not there anymore. So obviously this also has changed for whatever reason.
There's one more question here from the chair.
In your opinion, is it useful or not in this kind of patients to perform coronary angiography when they become symptomatic?
You mean the ones with the diastolic heart failure?
Yeah.
Yeah, that's what, cardiologists do catheterizations anyway, whatever the situation of the patient is, at least in my country. Now, I think it makes a lot of sense because what you have to exclude is that they have overt coronary artery disease. And coronary artery disease can sort of, in the first time it could show it that way.
Thank you very much. No other questions. Thank you very much. We can move to the next speaker.